first speaker, James. James Sumner is the Chief Executive of the University of Hospitals Liverpool Group. James has been championing and leading the transformation of healthcare in a number of his leadership roles, currently as CEO of the Liverpool Group, which was recently formed. James has been pioneering the use of data to drive better management decisions and patient outcomes. He will now share his perspective with us and experiences of using data for decision making at board level, the art of the possible, and what boards can do to upskill. So James, straight over to you.
Thank you, David. Good afternoon, everybody. I'm just going to walk you through in what will seem like hopefully a quick but hopefully informative session, just about some of the perspectives in my recent experience in my last few organisations of trying to resolve this issue of data versus insight and what all that looks like from my perspective. So I wanted first of all just to sort of describe, because I know we've got people from all different parts of the world on the call today, that it's been a really interesting and eventful year for the NHS in the UK. We've had change of government, public interest in services, and a view that the NHS is in a difficult situation, high profile issues, real focus on leadership at the moment. And it's not an underestimation really to say that the current system is a bit broken, although recent use of that at a political level sort of backfired slightly, in the sense that it is recognised that there is still a lot there to be proud of, and it's just about how we reorganise it. I think really for us, what we see in our hospitals, of which we've got 4 separate hospitals within the City of Liverpool in our group at the moment, is just an increasing burden of care, workforce capacity, challenges, all of those things, and healthcare is getting much more complex and complicated. But a top-down driven planning process just isn't allowing us really to think our way out of this. It's just reinforcing it. So if we can go to the next slide, please, I'll explain a little bit what I mean about that. So healthcare realistically, as I say, is getting more complicated. And at the moment, that top-down driving of how we're forced to plan is a real concern, because it tells us what the answer is and asks us to work back. And I'm going to come on to that in a second. And we've also got this real paradigm shift now around how we're going to make this left shift in healthcare, but no resource planning or multi-year processes to change it. So as leaders and board members within our organisations, more so than ever, I think at the moment, we're being challenged to make decisions constantly about balancing quality, experience, safety and resources within those regulatory constraints. And at the moment, that's probably becoming a weekly thing rather than an annual planning cycle. They're really difficult decisions we have to make on a weekly basis that take us in this direction. So this is where, from our perspective, data and innovation can help in the boardroom and at the front line. And we know that the NHS is not great at pulling data together in a way that turns it into actionable insights. So what we do is we tend to look at things in silos around that regulatory framework, so functions, divisions, benchmarking, and it continues to just lead us down the same path, and we need to get the basics right, as Naeem said earlier. So I was going to share a couple of examples of work that we've been doing over the last few years with Stratasys, one from a consumer perspective and one from a staff perspective. And the pictures on the screen here are taken from our consumer analysis in one of the trusts that I was working at the time. So I'm going to start there. So if we can go to the next slide, what I wanted really to stress is that if we're looking at how we do a better job of improving care and outcomes for the populations we serve, you can't do that particularly well in the current NHS planning approach, which, as it demonstrates on the top there, you almost get given the answer round about Christmas Eve with a set of operational planning guidance that says, here's what we need you to do, and here's what we want the outcomes to be. And then you work through that left to right in terms of, well, that's the answer I need to provide. These are the regulatory compliance situations I'm going to be in. This is the money I'm going to have to do that. And then you start to work out, well, how am I going to work through that? So cut my cloth accordingly to deliver things to try and get that outcome. And you wouldn't do that really in any other industry. And what we've tried to do in previous iterations of this work with Stratasys, and I think successfully, is do that the other way around and look through that partnership approach, so from the right to the left. And population needs, behaviours, motivations are critical to that. So to give you an example of that, you can see just in the bottom right-hand corner an example of one of the segmentations of population that we used in another organisation that we worked with Stratasys on. And what that did was really move away from statistical data cut by age group or cut by sex or cut by specialty, and start to get the magic of connecting and triangulating that data to understand more about our patients, who they are, their needs, their wants, their motivations. And what that did was really help us understand how to serve them, their unmet needs, and really importantly, understand how they choose, how they access services. And when we started to get into that, the board at the time had a real light bulb moment with this. What we were doing previously was looking at things in categories of specialties, and patients don't arrive with a sticker on their forehead saying cardiology or respiratory anymore. They're multi-morbid, multi-complex. And what we really needed to know was, what do they actually need? Where are they landing within the organization? What's their utilization looking like? And in that example, you can see on the bottom right of the screen there, we found that the most complex elderly patients were actually only just slightly more than 1% of the patient population. But in terms of their utilization and the complexity of need, they were using huge amounts of resources within the organization because of our inability in that sort of linear hospital process to get them multi-specialty advice and to put together the right packages of intervention that would get them the outcome that they wanted. So by starting to connect that data in a very different way, we'd be able to come up with really radical and different solutions, but also capabilities that we need to develop at an organization. Because what we quickly realized is we're built and constructed to do things in that very linear specialty focused way. If we're going to move into doing something much more partnership, much more integrated, we actually need to learn how to respond to that, not just as groups of clinicians, but as groups of corporate services, or the way that we look at things from a staffing perspective or a digital perspective, for example. So by doing that and really understanding with a sort of deep level of insight what was going on in our population and what they needed and what they wanted, and what the key elements we need to focus on as a board, we became much more confident about the decisions that we made. And key to that was this sort of open book approach, where we got our executives then, who all previously were leading their individual pillars within the organization, to start to work horizontally. We had the chief people officer leading the digital agenda, pushed them outside of their comfort zones and started to think about how we could apply data differently, but more importantly, how we could start to integrate the way that we do things for certain cohorts of population, and understand that not everything had to be done in the same way for these different cohorts. So what we got there was real help and guidance to use that data. Stratis provided coaching, mentoring through the process, and it made a big difference. And we actually managed to go from a set of population segmentation quite quickly to something that spread out to the wider system. And our partners in the system, in the councils and the other NHS organisations, started to say, well, hang on, these are our patients too. It's the same population. These are our customers. They need the same thing. So how can we start to do that? And probably within less than 12 months, we went from a view of what this looked like within a hospital setting to pooled budget discussions around how we could allocate resources to particular parts of our population across multiple organisations. And the real test there is when those data-led decisions result in actions and outcomes that people can see and feel on the ground. And that was the first time I think a lot of those staff were involved in multi-organisational discussions about solutions for these people. Moving on to the next slide, just briefly, a similar but different approach around, okay, well, if we can take that sort of data level insights into what our population need, how can we do the same with our staff? Because another major challenge in healthcare for us at the moment is our staff, lack of capacity, capability, skills, current needs. And again, really interestingly, the sort of national directed approach is to sort of talk about headcounts and reducing headcounts and making sure we recruit and so on, but virtually no concern given to the changing shape of our staff and our workforce and what they're made up from. And so here we started to look again with Stratis at doing a very similar but slightly different analytical approach of our staff and trying to really understand what they needed. And what we found is the demographics within our staffing and our staff cohorts were significantly different. And this might sound really obvious, but I would imagine that most NHS organisations and perhaps many others don't necessarily understand how many of their staff are in certain generational types, jobs for life anymore, and want flexibility and mobility. Yet what we're doing is starting to move towards trying to rigidly recruit people into permanent jobs because that's the national direction of travel in reducing pay costs. And what we found really early on is that we had a huge cost in staff moving around the system because the flexibility wasn't being given within, and the cost of that being multiplied at every move. So we really, again, looked at needs, behaviours, motivations of staff, triangulated that data with things like the staff surveys, and got to, again, a very similar set of light bulb moments of, well, look, there's a cohort of our staff here who the last thing they want is a job for life. What they want is flexibility, the ability to do things part-time. And we started to gradually understand that something like 50% of our staff were answering these questions to say, actually, I would rather work flexibly part-time, and I'm not really interested in a long-term career anymore. That leads to very different insights when you start to think about your recruitment strategies in the future, particularly in healthcare, where it's not been like that for a long time. We were also able to understand what was important to them, who took notice of managers, for example, versus who didn't really care what the managers were saying because they felt that their resources and their workforce offer could be undertaken anywhere. So they weren't really interested in what the organisation wanted to do long term. Yet we had other cohorts who were lifers in the organisation, and what the organisation wanted was really important to them, and they felt differently. So the point here is we've got data everywhere, and we get loads more data. And yes, it's imperfect, but the real value here isn't the technical aspects of it, but it's building those capabilities to translate those data into insights and then action. And that was critical here, because in all of these instances, what we started to do was give staff the decision-making ability to say, well, if this is what our patients need, here's how I would cater for that, rather than a huge annual planning exercise that's driven down certain alleyways. So I think within all this, back to what Naeem said at the beginning, we really need to get to a place where the basics are right. Decisions are owned by management, get away from benchmarking things that are done the same way, and start to bring that data to life, storytelling from data, bringing it to life for staff and patients. When they feel those changes are happening as a result of that, you do start to get the ball rolling in a different way. So they were a couple of examples that I wanted to share today, and I think I'm on time, so I'm going to have to leave it there. Thank you.
Thank you very much, James. Just one question before I move on to our next speaker. You talked about the work that you've done with Strasis, James. Can you just say a little bit more about the impact that's had on you and how it's made you think and lead differently?
Yeah, absolutely. So again, I come back to that sort of triangulation of data point. We were constantly in this cycle of looking at individual pillars of data and individual slices of it, and that ability to triangulate was the thing that was bedeviling us, really. So back to that insight thing, I think the two big things were the ability to reduce complexity and triangulate, and then coaching were the two big important things that Strasis did with us. They coached the board, non-exec directors, exec directors through that process. So we really got a deeper understanding. So those are the two key things for me, the complexity unraveling and triangulation, and the coaching of the board and the executives about how to listen and use that in a different way.
That's really impressive. Thank you, James.